Good afternoon, all. At the outset, I would like to thank the organizers of the AIOS for the opportunity. I have no conflicts of interest. And my topic is lid lumps and bumps and overview. This is of interest because we have these lid lesions which can arise from any layer of the skin and can be malignant, pre-malignant, benign, painful, painless, and the list is endless. So when we come to the benign ones, the so-called good lesions, starting from just the epidermoids or the sebaceous cysts as was previously called, and then the melia, which are the white keratin bumps under the skin, then the molluscum, which is the pearly nodules, the xanthelasma, which is the yellow subcutaneous plaque, and the seborrheic keratosis and the papillomatous lesions. The seborrheic keratosis, which looks like a well-circumscribed stuck-on lesion. What we need to remember here is if you have a sudden onset of multiple crops, then we need to rule out an internal malignancy, a GIT malignancy. And then this is the case of the cutaneous horn, so-called because it resembles an animal horn. The horn itself is not of much interest. It is because it's just made up of dead keratin. But then the underlying condition may be pre-malignant or malignant. So it is always mandatory to ensure a histopathological diagnosis and go on accordingly. Of the common dermal lesions, we have the nevi, which usually these lesions are congenital or seen in early childhood. And here was a patient who presented with a painless lesion since childhood, but then he came to us in the third decade, and on excision turned out to be a hemangioma. Of the adnexal lesions, we all know the chalasia and the hordeola are so common. Apart from that, we have the cystic, the hydrocystoma, which are solitary nodules, which are smooth and found along, arises from the cysts of Moll. And if they contain clear fluid, then they transilluminate, otherwise they don't. And then the syringoma, which are multiple, waxy, elevated nodules. So most of these cases can be treated by a simple excision or shave excision, or maybe a laser or a carbon dioxide as well. And here are some other lesions of the typical S-shaped lid of the neurofibromatosis, and as ma'am already spoke, necrotizing fasciitis, the dermoids, then cellulitis, and these were two interesting patients who presented with malformations. This was a 30-year-old lady who had come to us for recurrent swellings of the upper eyelid, and these which increased on valsalvas. So here it turned out to be a lymphovenous malformation, and so we had advised her for sclerotherapy. And this was another patient who was referred to us from an outside center as an AV malformation who had already undergone partial embolization. So coming to the next one, which are the pre-malignant lesions, which are definitely not so good lesions. We need to keep these four in mind. The actinic keratosis, which is just having a sandpaper-like texture. Then the keratoacanthoma, which is a kind of a nodule on the lid with a central crater filled with a keratin plug. And then the bovins, which is an erythematous elevated plaque, and lentigo maligna, which deals with the hyperpigmentation. So here it is important because we need to excise with an adequate surgical margin and always follow up on the patients. Finally, the most malignant ones are the very bad lesions. So we know that skin cancers are the most common malignancies, of which eyelid malignancies make about 10%. The basal cell carcinoma, though very, very common, in our part of the world, in the pigmented population, it is the sebaceous gland carcinoma which takes the upper hand. And the risk factors to be kept in mind, so fair-skinned individuals, immunocompromised, or with previous history of radiation or burns, or even, and then beware of the signs of malignancy. So these are the red flags. When you have the normal lid architecture which is altered, think of malignancy. Then if there's a loss of lashes or tethering to deeper structures, and then the ABCDE, where there's a change in the color, the border, or the size of the swelling, and then the fine telangiectasia, please keep in mind, we are probably dealing with malignancy. So the basal cell carcinoma, we all know that we have the nodular form, the ulcerative form. This was a lady who was referred again to us with query malignancy, query granulomatous lesion, and it finally turned out to be a basal cell carcinoma. These are locally invasive, so we need to ensure that we treat them right away. This squamous cell carcinoma is less common but more aggressive, and the thing to be kept in mind is that here metastasis happens through the lymphatics, through the blood, and through direct neural spread. So definitely it is mandatory to do a regional lymph node examination and a thorough systemic examination. The next is the sebaceous gland carcinoma, which is also called the great masquerader, because of it can mimic chalazion, it can mimic persistent blepharitis. But then the points to keep in mind are the yellow appearance because of the lipoid material, and the loss of the lashes and destruction of meibomian gland orifices. This is very important because it is potentially lethal because of the pagetoid spread and the multicentric origin. The less commonly seen cancers, the malignant melanoma, to be suspected in any individual who is beyond 20 with a fresh new pigmented lesion. Then the Merkel cell carcinoma, which is pretty rare. The Kaposi's, which can be seen both on the eyelid and in the conjunctiva. And finally, to keep in mind, metastasis to the eyelid, which can occur from anywhere else in the body, commonly the lung cancers and the renal cell carcinoma. So surgical management for all these malignant lesions definitely will need surgery unless they are in a very early stage where we can go for alternate forms as well. So it is mandatory that we go for a wide excision. That means leaving at least with a 2 to 3 millimeter margin of normal tissue, preferably with a frozen section control, if not for Mohs micrographic surgery, where tissue preservation is better. And the biopsy can be either the excisional or the punch or the incisional biopsy as well to confirm the diagnosis. And having done with resection, we can think of lid reconstruction, where the principles are, if it's less than 33% involvement, where we go for a primary direct layered suturing, or if it extends up to a 50%, then we go for, as in this case of the basal cell carcinoma, where we went in for a suturing with a canthotomy cantholysis and a Tenzel's flap, and we are having the follow-up as well. And here in the case of the sebaceous gland, where there's more than a 50% involvement, either we can go for lid sharing procedures. Here we went for a cheek rotation flap, the mustard procedure. So my take-home message is a meticulous history taking and clinical examination will go a long way in identifying these lesions early, have an index of suspicion, look out for the red flags of malignancy, look out for the regional lymph nodes, and do a thorough systemic examination, confirm the diagnosis, then ensure a proper complete resection with margin clearance and a follow-up, and if adjuvant therapy if necessary. So I would also like to acknowledge my mentor, Professor Samrapuri, who's the HOD of the Department of Ophthalmology of Stanley. Thank you.
Excellent presentation, Doctor.
Thank you, sir.
Any questions from the audiences?
Ma'am, regarding the surgical management protocol, you said the wide margin excision 2 to 3 millimeter beyond. Is it so, or some says 4 millimeter?
Yeah, it depends on the clinical presentation, what we are suspecting. Suppose if it's a sebaceous gland, we know we are going to have skip areas, so we need to be extra careful, go in for a wider margin there, whereas in the others, maybe a 2 or 3 mm would suffice.